Three, two, 1, 0.
Welcome to the Heart of Innovation, 60 minutes that could save life and limb, with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by patient advocacy group thewaytomyheart.org in partnership with Abbott. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of The Way to My Heart, Kym McNicholas, and interventional cardiologist and founder of the Save My Piggies Health Education Series, Dr. John Phillips.
Hi, everyone, and welcome to the show. When you think of Olympic athletes, you think of the epitome of health, a dedicated group of individuals whose whole life revolves around health, well-being, and pure performance. Individuals who would be a cardiologist's dream patient, the poster child of compliance. The last thing you would think of with some of the fittest men and women in the world is their risk for a heart attack. Now, while endurance exercise can provide powerful protection against heart disease, it turns out it also has the potential in some athletes to bring on a troublesome arrhythmia called atrial fibrillation, or AFib. And over the next hour, we are going to talk about AFib, what it is, who's at risk, and why complications stemming from it are leading to people having a heart attack. We're also going to talk about some treatment options that are available. We have electrophysiologist and cardiologist Dr. Joseph Bumgarner, who's with us. He is from UNC REX Healthcare in North Carolina, and we're going to get to him in just a moment. But first, hello, John. How are you?
So happy Saturday, Kym. I'm sorry I'm laughing. I was just, as we went on air, my office window overlooks my driveway, and I see my son has a dirt bike, which it's like electric, but it can go like 25 miles an hour, and he's supposed to wear a helmet, and he's flying down the driveway with no shirt on, no helmet, and he's holding a fishing rod in one hand. So I am just, scratching my head. I'm a little vexed right now. So anyway, yes, I'm happy.
The commercial break, you were going to see him running down the street after his child.
Anyway, yes,
awesome.
an interesting topic for today, and we were sharing before we went on. We don't typically have electricians on the show, and mainly plumbers, so this is a good change of pace.
Mm-hmm.
But I wanted to start the show with a little bit of a sad commentary and a very sobering kind of experience that I had with a patient. So, and I don't think this, obviously with HIPAA, we're not going to share this gentleman's name. But so I ended up seeing a gentleman who was admitted to our hospital on Friday after a suicide attempt.
Oh, no.
And we don't, so again, I saw him for a vascular issue. Well, I came to find out that this gentleman was having so much pain in his foot because of ischemia and lack of blood flow. And he had gone to several facilities, I believe in our area, multiple attempts at revascularization to improve his plumbing that failed. And so he decided that he was going to kind of end it. And he wrote, and I have, he wrote a suicide note, honestly. And I'm going to read it here because this just kind of shook us. And I remember it was in his chart. And so we all kind of read it after the procedure that I did. But it basically said, "I can't take the pain anymore. This has always been my destiny. Just want all the pain to stop." So I started to wrap my head around that, thinking, what a failure, right? Like, this poor guy is asking for help. We meaning the healthcare system, couldn't get him the help he needed, and he was considering actually he had tried to overdose on fentanyl or something, and thankfully somebody saved him. He ended up getting taken to our hospital, and so I did a procedure, and we got some blood flow back, and he actually was very, very thankful on a number of levels. But it was just so sad to me and sobering. But what I told my team was, because they love me, I think, but sometimes they're like, "Oh, he's doing another one of these pedal access things," and okay, crazy procedure type stuff. But I said, guys, this is why we do this. This is why we do this. And again, you and I have talked about this many times, but I've never seen an attempted suicide because of foot pain due to ischemia before. So again, we've just got to keep our finger on the pulse here and raise awareness and continue to educate folks as we push on.
this is something that we see actually at the Global PAD Association every day. And doctors tell me that they think it's just, oh, that's just an isolated case. That's the exception to the rule. They don't understand. I don't think, I mean, honestly, do not think, and you can probably weigh in on this. Did you think, after I say this, that PAD is this debilitating? PAD is one of the most debilitating diseases that is so under addressed. And when I hear doctors every day fighting for their own limitations and putting things out in the media saying that these patients should not be treated, don't treat them too soon. Let's just wait till they're a toe step away from amputation. Let's wait until they overdose on fentanyl. Let's wait till they decide that they're going to steal items from Walmart just so that they could go to jail. Remember that story? The patient,
I forgot about that.
Dr. Bumgarner is here too. You can always join in, Dr. Bumgarner. John and I could go on forever, but there was a patient that we had on recently that she actually was in so much pain and was being ignored by doctors. She didn't want to be a burden on the healthcare system or on her family anymore, couldn't afford it. Insurance was gone. So she pretended that she was going to steal items from Walmart, stood at the door waiting for the police to come. And the police said, why did you do it? She said, I just don't want to be a burden on my family. This ischemic pain is too much for me. I need to go to jail so I can get the care I need. And that's sad. That's the reality of what we are seeing every day. And this is actually the 4th suicide attempt that I have heard of from PAD in just the last year. This is the first one that was not with us, but we've had 3 in the past year that we've had to help talk down from the ledge. It's really a debilitating disorder and should never get this far. It needs to be taken seriously.
Yeah, sir. A lot to digest there and unpack, but at the end of the day, this gentleman had options. He didn't know what his options were. We failed him as a healthcare system, and he almost lost his life. And then to actually to put more salt in the wound, he worked at this facility for 25 years. I forget what he did, and then his boss fired him because he didn't show up for work. I mean, it's like these people can't get a break.
No, not at all.
And I don't want to belabor the point, but it's just really, it's frustrating because there's a lot of good that can be done, and a lot of good done by you, Kym, and your team.
And there's a lot of good to be done by your team. You are Dr. Miracle this week, because we had a patient that was not being heard by her doctor, happened to be someone that a doctor that you knew, and you took a risk and you said, hey, you know what, let me just take a look at this patient. Let me see if a different set of eyes can do something. And it turns out that something could be done, and you were willing to take the leap and actually do it. And this patient calls you Dr. Miracle now, and we appreciate you for literally going out of your way to save some patients.
Honestly, and Joe can probably attest to this, I think most of us are pretty humble. It's just kind of part of what we do, and we're very thankful that people appreciate it. But honestly, I don't know that I went above and beyond. It was just kind of an assessment that we made as a team. And I just, again, we weigh risk versus benefit and reward and whatnot. And it was a pretty easy proposition for me. So hopefully she does well, and happy to help.
Yep.
Very sweet family.
Just always making sure you're taking a patient-centric approach to practicing medicine. Well, coming up right here on the Heart of Innovation, we'll take a moment to introduce you to Dr. Joseph Bumgarner. He's been sitting on the sidelines waiting to jump in, and we'll hear some of his life and limb-saving stories coming up in a moment. So stay with us right here on the Heart of Innovation.
Leg health can indicate risk for heart attacks.
Hey, Colin, can we powwow this week? We have a couple changes that I need to. That commercial I'll probably just need to change because right now Abbott, we're in the middle of hopefully maybe getting a sponsorship from them. I'm hoping, pray to God. Because
all the work that I'm doing for those guys, they better give us a sponsorship.
Yeah, Medtronic. Did you see my email? Medtronic turned me down in the rudest way. We don't have enough money to give you. What are you really? I messaged John Laird and I was like, okay, John, copy and paste what I'm writing here. And please help us get some funding from them. Seriously. But I'm hoping Abbott will, but they're not, if they do it, they don't want their name on it because it's a grant. And so while they grandfathered in from CSI's request to have their name on it, Abbott,
Okay.
since it's a grant through Abbott, they can't have their name on it, unfortunately. So
That's
which,
curious.
you know, I know, since it's not a sponsorship, it's an educational grant. There are rules.
Well, either way, I mean, that would be nice if they could come through.
It would be nice. I don't know. There's like this weird separation of church and state.
Oh, they're yeah. I mean,
Everyone, just want to give a heads up. 15 seconds till we air.
John, you taking us back in? Are we doing moment of inspiration?
That's the main thing right now. And then Kym, I
Yeah,
will
they
talk
can
to you
clear that up,
after
maybe.
the second break on some audio stuff. It's nothing bad. Just I'll talk to you after it. All right, everyone, let's get ready. In 3, 2, 1, let's go.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Should we do our moment of inspiration, Kym?
I think so.
Dr. John Phillips' spectacular vascular moment of inspiration.
And just as though like the fog kind of lifts and the sun is shines through, the sobering comments that I made are all kind of washed away when we hear the noise of the moment of inspiration. So
I love it.
on the heels of the Olympics, the Olympic Games in Paris starting, I have a quote from Pierre de Coubertin. I'm sure I'm mangling his name. He's a French educator and historian and considered the founder of the International Olympic Committee. And he's quoted as saying, "The important thing in the Olympic Games is not to win, but to take part. The important thing in life is not triumph, but the struggle. The essential thing is not to have conquered, but to have fought well." What do you think, Kym?
Wow. I went to apply that to medicine because I always want to win. I always want those piggies saved.
Well,
We-
but
piggies for the win.
that's true.
No, but I
Try to
get
save
what
the
you're
piggies.
saying.
But,
It
right, I mean,
is.
like,
But
you got to fight the
hey,
fight.
you do. You got to take the leap. You got to try. And there was a quote that I shared with you from a good friend of mine, Candace Barr, that she was saying that you need to not fight for your own limitations. You need to always take the leap. You need to fight, fight, fight. And I think that you're the epitome of that. Dr. Bumgarner's the epitome of that. I think one of his colleagues, Dr. George Adams, is definitely the epitome of that. So all of you doctors that are literally fighting for life and limb every day, definitely are the poster children of your quote.
Well, thank you. So let's welcome Dr. Joseph Bumgarner to the show, an electrophysiologist from North Carolina. Joe, how you doing? Thanks for joining us. Happy Saturday. How's the weather down in NC?
Hey guys, thanks for having me. Well, it is beautiful. It's about 90 degrees here. One interesting fact about George Adams is that he drives an F450 with a cattle trailer attached to it to the hospital, and he inspired me. I have one as well, and I spent my morning washing it, and so it's been a good day so far.
What a 450? So is that like a dually or something?
It is. It's embarrassingly large.
Awesome.
And, are you herding cattle as well?
No, I have 3 wonderful daughters, and that's enough for me.
That can't be like herding cattle.
Does a truck like that fit in a normal parking spot?
So it perfectly fits line to line by most standard parking spaces, but you've got to get it just right for it to fit.
Awesome. So speaking of getting it just right, tell us about atrial fibrillation. So the lead into the show was Olympic athletes and potentially having an increased risk of dysrhythmias or abnormal heart rhythms. Tell us how you got into the electrical world as a cardiologist and why you have some fascination with Olympic athletes and atrial fibrillation.
Yeah, so I would just say that, like most of us, the reason we find our way into things is the mentors that guide us and kind of the people that come in our way. I just happened to fall into a job working with an electrophysiologist in Wilmington, North Carolina, at the beach, which was pretty inspiring. And we just had a blast learning about this world of electrophysiology. I knew that I loved cardiology. I knew that I loved blood vessels and opening blocked arteries and heart attacks and all of that, but I didn't really realize that there was this whole other world of, electrical conduction problems with the heart, and that there were opportunities in that field to really impact patients, to really impact their quality of life, especially with certain arrhythmias. The word cure was being used in this clinic, and I couldn't believe that. We were managing high blood pressure and managing coronary artery disease, but then we were curing certain arrhythmias. And then being in EP or electrophysiology, you just can't practice that without being surrounded by atrial fibrillation. It is the fastest growing sort of public health epidemic around the planet, and it is just growing by leaps and bounds. We don't fully understand why, but what's interesting about it is there's this dichotomy. It happens in patients that are chronically ill, that have a lot of other health issues. And then the longer you practice, you discover it happens in very healthy young people that are doing the right thing. And so it sort of, in a way, found me. I have this wonderful group of athletes and cyclists and marathon runners that
Wow.
are developing atrial fibrillation. And it's just a curiosity of why that happens.
That must be so frustrating for these patients, and something that you say, you know what, I know you're doing the right thing, and they must come back at you and say, is there such thing as too much of a good thing, doc? And how do you respond to that?
Well, it's a great question. And I think that at some level, it probably is too much of a good thing. I think, our heart is a muscle, our heart is an electrical system. It has a certain optimal running speed. The best heart rates to develop cardioprotective benefits are not max heart rates, and they're not heart rates that last forever. It's really just a contained amount of time, 30 minutes to an hour, most days a week, getting your heart rate into that 50 to 70% peak heart rate range. That's where most of the cardiac benefit lives. And so a lot of athletes are really outside of that range. And I think over time, like any muscle, it puts it under extra stress.
So can
I
you go
had
into the basics? Sorry, I was going to ask you go into the basics of atrial fibrillation. Like, what is it? What is the mechanism of action for this particular disorder?
Yeah, AFib is the most common arrhythmia that we see. And I think to talk about it, I always like to talk to my patients about what normal is. Normal in our hearts, I describe our hearts kind of like a house with an upstairs and a downstairs. The downstairs are the ventricles, the downstairs are the big muscular chambers that are beating, but they really don't beat on their own very well, and they need a pacemaker. They need an instruction from the top floor of the house. And so we're built with a pacemaker that lives in the top right-hand corner of our house, and it sets the rhythm of our heart beat after beat. And we have about 1 million heartbeats every 2 weeks. It's miraculous. It's amazing. It starts when we're about a month old in our mother's womb, carries us through our whole life. But there are other pacemakers that, if you wind the clock back when our heart is forming, and our heart's really just a tube, and it hasn't twisted and turned into that 2-story house as I was describing, our natural pacemaker, another part of the heart called the AV node, and then this extra part called the pulmonary veins. The pulmonary veins, all three of those things, the sinus node, the AV node, and the pulmonary veins, they all originate actually from the same place from a congenital perspective. And so as you fast forward through life, there are other areas of the heart that can fire like a pacemaker, can fire like this spark plug that makes the heart beat. And so the pulmonary veins are the source of the bad electrical sparks that can spin the heart out of control into AFib. And what happens is those top chambers, rather than beating in a very organized way like they normally do when we're in normal rhythm, they just sort of quiver because that electricity is beating in a very erratic way. And it causes the heart to beat too quickly, too slowly, erratically, irregularly, and it can be pretty uncomfortable.
Well, coming up right here on the Heart of Innovation, we'll have more with Dr. Joseph Bumgarner with UNC REX Hospital in North Carolina. So stay with us right here on the Heart of Innovation. Don't go away.
3 years ago, my symptoms.
John, is that okay?
I suspect we're clear. Yeah, that was great. I mean, I love the analogy. I've never heard the two-story thing. I love it.
Yeah, I'm
And,
saving that one.
that's a good one. I think continuing, Kim, if it's all right, we can continue the conversation about AFib and then how that morphs into, because I think it's very fascinating to me about that peak level of, I guess, heart rate variability or during exercise, maybe potentially being at risk for developing AFib if you exercise, too much of an endurance athlete or kind of wind the motor too tight for too long.
Yeah, and then there's the other side too, is most of these people are really bradycardic when they're just resting, and so it just gives more room for the pulmonary veins to fire and to do funny things.
Oh yes, that's it. I guess I know. Okay, that.
If you've got a resting heart rate of 30,
yeah.
there's just a lot more time for other things to start firing. And
yeah, that's a great.
You've got a big heart, you've got a muscular heart, and it. Yeah. When I was at Cleveland Clinic, we did all of the echoes for the NBA and the NFL.
Mhm.
I mean, all these hearts look
How cool.
Yeah, they all look like almost like hypertrophic cardiomyopathy. They look like they're developing heart failure. I mean,
Did you train at the clinic?
Yeah.
What? Let's see. We've got 3 guys from the clinic in my practice, but I don't. So Mike Jolly, I'm in Columbus, Ohio. So we had 3 interventionalists: Mike Jolly, Chris Huff, Joseph Campbell.
Joe Campbell. Joe was a year ahead of me. Yeah.
Okay. Yeah. So Joe, because Joe was at the clinic for a few years practicing, and then he left and joined. I think he's been with us 3 years now.
Yeah. Is he doing okay?
Oh yeah. He's a good egg.
Yeah.
Joe makes me laugh.
He makes me laugh too.
Yes. He talks really loud. I'm like, Joe, are you deaf or something? Because you talk so damn loud. But he's very thoughtful, loves his patients. He's a good egg. I will definitely tell him you said hello.
I want to say hello. He's such a good family guy too.
Oh yeah. Yep.
That's awesome.
So how long have you been at Rex?
I've been there 5 years.
Okay.
Well, wow, 6 actually. Yeah, time's flying.
Yeah,
so I think COVID got caught up in that whole whirlwind. And
last time I talked to George, I thought there was an ASC or OBL that y'all had. I don't know. Are you involved in that too?
Yeah. So EP, the legislation is supposed to change soon on that, but right now it's peripheral. But we're hoping soon. But they're doing really well.
Well, because the reimbursement, my understanding, in those ASCs is pretty good for some of the procedures you guys do. Yeah. So that hopefully it'll change. In Ohio,
they have so many costs, though. They have so many other.
All right, everyone, we're going back in 5, 4,
it kind of works out.
3, 2, 1, 0.
For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thank you for joining us. We are starting to scratch the surface on the most common dysrhythmia in the United States and the world wide, I believe, atrial fibrillation. And Dr. Bumgarner was sharing with us a wonderful analogy about a house and 2 stories and making sure that the pacemakers from the top are acting appropriately, and oftentimes they don't in atrial fibrillation. So, Joe, we know that atrial fibrillation is a problem in and of itself with respect to the heart not beating right, but there's also risk of blood clot forming and stroke. So it's kind of like a double whammy, right?
Yeah, it's, AFib, and I always tell my patients, look, AFib is not a life-threatening rhythm. It might be a quality of life altering rhythm, but I always tell them there are 2 rules. And the first one is no strokes allowed. So in 2024, we really should not be having strokes from atrial fibrillation or blood clots. And thankfully, we have some great medical options to treat that. And then the other side, the other rule that I have is no heart failure allowed, because when the heart runs too quickly and too erratically in AFib for too long, it just wears out. It's just the extreme. Imagine you exercise. Imagine you're running constantly. That's what AFib is. And if the heart doesn't have time to rest, it's a muscle. At some point, it just fatigues and wears out.
Do
So what
most people?
typically actually triggers? We're just bombarding you. It's like the
We are.
firing
Too
squad.
many questions. Exactly. Firing inappropriately. We're firing inappropriately.
Exactly.
Kim. We're having AFib on this.
We're just
interview.
staying on topic as always.
Exactly.
You couldn't have more fun in an interview.
No, you couldn't.
Dr. Joe. So what was your question?
Mine
Dr.
was
John?
like, and I know the answer to this, but I want Joe to explain it. Does everyone know they're an AFib? Like, do you?
Oh,
Right. Because you
what
said
a
it's like
great
running.
question.
Yeah.
What a great question. And so I think doing this long enough, I do believe there are people that don't know that they're an AFib and really can't tell the difference between what normal feels like and what AFib feels like. And I would say it's actually miraculous. We don't feel this muscle in our chest beating all the time, but we don't, which is amazing. But what I always challenge my patients with, if I meet someone that's in AFib and they tell me, I don't feel it, I feel fine, I'm doing well, I'm okay, I say that is okay, but let's prove it. And so I usually do what's called a trial of normal rhythm. And so we usually use a medicine, or we do what's called a cardioversion, which is an electrical resetting of the heart rhythm back to normal. And then I see them back. An example, I saw a patient this week, completely asymptomatic, of course, super athletic, great guy. We did a cardioversion and I saw him 5 days later and he says, I feel like a new person. I realized I was carrying a backpack on my back for the last 3 months and I had no idea. And now I sleep better, I exercise better, I feel more like myself. So I always sort of challenge them in that regard.
See, that's the sign though of a good doctor. Asymptomatic is not necessarily asymptomatic. It's the doctor not asking the right questions to determine if the patient is in fact asymptomatic. But of course, looking back, the patient will look back and go, wow, I was symptomatic, right?
That's
and
right.
I think that that's the case with a lot of these patients. I also find that with PAD patients, that the patients just don't realize they're walking slower to protect themselves, to prevent the onset of claudication.
That's right. And just like PAD becomes so critical at a certain point, AFib becomes so critical too when, the worst part of my job is meeting someone that has just had a massive stroke and they didn't know that they had AFib. And so that's why you see companies like Apple building in an algorithm into the Apple Watch, or you see another company like Cardia putting a home EKG monitor out on the market, is that, this is really a public health issue where we can really reduce the risk of stroke for so many people around the world just by detecting AFib.
Why is AFib so rampant? Who's at risk? What triggers it?
The answer I usually give is yes. It is okay. So it is part of being human, and I don't fully understand it. At the microscopic level, it gets down to calcification, the same stuff that causes stiff joints and arthritis, the same stuff that causes macular degeneration. It is part of the stiffening and the aging of the heart muscle. There's no question. Is that the electrical connections, cell to cell, when they start to get filled with calcium in the spaces between cells, electricity just doesn't move as well. Sometimes during an EP study, when I have a teenager that has a specific kind of condition in the EP lab, part of my job is to put them into AFib. I can pace aggressively enough in the EP lab and put them into AFib. And that's not that difficult to do. We all can go into AFib, but it's the sustaining of that rhythm. It's the keeping it going. That 15-year-old, 16-year-old, they're going to snap back to normal rhythm in a matter of seconds. The 40-year-old, the 60-year-old, the 80-year-old, they've built an environment in their heart where that spark can set off the fire and the fire can keep burning. But what causes it? So many things: high blood pressure, sleep apnea, obesity, poor diet, sleep apnea. Again, that's a huge one. So I'll say it twice.
But Joe, isn't it a function of just an aging population? I mean, I think, what is it? What percentage of people over 80 have AFib? For some reason, 20% or something like that sticks in my head. I don't know if that's right, but we're living longer, and people are getting AFib. But so how do you manage it? Like, tell us about the treatment options, not only for the rhythm issue, but then to prevent stroke.
Exactly. So there, just as you say, there are kind of two sides to treating AFib. And the most important one is protecting someone from stroke. Now, not everyone that has AFib needs to be on a blood thinner. Young people that don't have other risk factors their risk is just not high enough. And so we don't start powerful blood thinners in those patients. But when you build up enough risk factors, things like high blood pressure, previous heart attacks, vascular disease like PAD, age, being over 65, being over 75, there are risk score calculators that we use in clinic to talk to patients about, hey, your risk of stroke is 3% in the next year. There's a medicine that can bring it back down essentially to zero. And so we have those conversations. And so there's that side of treating AFib to prevent a stroke. But then there's the other side, and that's all about symptoms, and that's all about quality of life. That's all about keeping the heart in normal rhythm. And historically, there was this idea that keeping the heart slow, or what we call rate control, was a good way to control AFib. But over the decades, since the 1980s, tons and tons and tons of evidence tells us that rhythm control, keeping someone's heart rhythm, not the speed, but the rhythm in a normal rhythm, is so much more important. People feel better. Their risk of heart failure is lower. Their risk of stroke is lower. Their risk of dementia is lower. And so using certain antiarrhythmic medicines is an option. But I think for a lot of us, and for, the American Heart Association and Heart Rhythm Society, there's been this big move towards a procedure called ablation. And so most EP cardiologists, we spend most of our time doing ablations for atrial fibrillation, which is a process of just silencing those pulmonary veins and those kind of spark plugs that are firing inappropriately from those pulmonary veins.
What, real quick, because we've got about a minute and a half left, what do you quote your patients from a success standpoint and durability standpoint for an AFib ablation? Say it's the first one, because obviously they can have multiple, right?
Yeah, that's right. It has to do with how long they've had AFib. So for someone that has short episodes, a single ablation with current technology, the success is above 90%. One ablation, the likelihood of freedom from clinical AFib 5+ years, we would say is greater than 90%. If you wait, if you sit on it and you let AFib fester and get a root and a foothold, then that starts to come down. And for somebody that's in AFib all the time, maybe weeks or months at a time, I might say more around the 80% likelihood that a single ablation, not using medicines, but just the ablation alone, would keep them in normal rhythm with a single treatment.
And coming up right here on the Heart of Innovation, we'll also talk about some cutting edge treatments such as the Watchman. And we do have some questions coming in from our live studio audience. So stay with us. Don't go away. Keep watching the Heart of Innovation.
Everyone's clear.
Okay.
We could
This
talk
is
about
great.
AFib for weeks on end.
I know. I do want to, but you mentioned the risk factors, being, the age and things like that. But then how do you treat those patients, that are these endurance athletes different than you would someone who is more chronically ill and has these types of risk factors?
So because they exercise all the time, their heart rates are 40 or 50, they're sitting in clinic with a heart rate of 42, and you can't use medicines. All the medicines slow their heart rate down. So they're at this really nice sweet spot with a low heart rate. But if you give them an antiarrhythmic or metoprolol, their heart rate's in the 30s and they feel terrible. Plus, they can't get to their peak. They want to get to this peak heart rate. And they're really proud of that. They're proud of their low heart rate, and then they're really proud of the kind of endurance they can do. So medicine's a terrible idea. They do really well with ablation, actually. There's this funny phenomenon, though, with ablation, and I always talk to them about it. Their heart rate actually will come up. So after an ablation, I usually tell them your resting heart rate will be 10 to 20 points higher. So if it's 50, it'll probably be 70. And a lot of them hate it.
They don't like that, I bet.
They're so self-conscious of that, and they compare it to their buddies, and they hate that.
But they're better. They're better.
It's the weirdest thing. I think it's just the strangest, weirdest thing.
So we have Nancy, prepare. We're going to get you on with your question, and then Douglas has a question and Marcia has a question.
All right, everyone, heads up. 10 seconds till we air.
So, John, you want to get into the cutting edge treatments and then we'll throw into the 3 questions?
Live in 5, 4,
Stay
3,
muted till we call on
2,
you.
1, 0.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for joining us. Let's continue our conversation with Dr. Bumgarner regarding atrial fibrillation. Joe, so as we went to break, you were kind of sharing with us some of the treatment options. Before you get into, so let me ask you this. There are some people that need anticoagulation, and if I remember correctly, the folks that are at highest risk based on their scoring system, which you had alluded to, often don't get anticoagulated because they're at risk for a fall or things of that nature. So now we have a minimally invasive way to help reduce the risk in these folks. Is that right?
That's right. So a lot of patients, they're at risk of falling. They've had bleeding in the past. They've had bad GI bleeds. And so they just can't take these medicines. And so in those patients, over the last decade, there's been a device that's come really into the spotlight called Watchman. And it is essentially, I would describe it to my patients, imagine a plug in your bathtub or your kitchen sink. That's what it is. So there's this part of the heart called the left atrial appendage. We have known that's a problem in AFib for decades. If you have open heart surgery today, and you have AFib, a surgeon will cut that off. This little pouch, this little windsock that hangs off the side of the heart, it doesn't serve any function except that it has a lot of nooks and crannies and blood clots form in there. In AFib, they can form, then bounce out and cause a stroke or a clot somewhere else in the body. And so Watchman is where we target that windsock, that extra appendage on the heart, and we essentially seal it with this device.
Does that mean once you have the Watchman in place, so 2 follow-ups. Once you have the Watchman in place, you no longer need anticoagulation moving forward, assuming it's successful? That's my first question. And then my second question is, out of the clot that people get from a stroke from AFib is what percentage? 90+% from the appendage? Is that what you tell folks?
I would say it's above 95%.
Okay.
There's no question. There's this inflammatory issue with AFib where clots can form in other places in the heart, but the vast majority form in the left atrial appendage. The issue about continuing anticoagulants after a Watchman, that's always a shifting ground, but the FDA recently approved dual antiplatelet aspirin Plavix or another combination for 6 weeks after a Watchman, and then usually just aspirin alone as a single antiplatelet. So yes, they can actually get completely free. They can become free of their anticoagulant.
What's the maintenance, durability, and indications for the use of a Watchman?
So the Watchman itself really just creates a scaffolding where the body, the human heart, regrows a layer of tissue over the top. And so it's actually the patient that is sealing the appendage. The Watchman's not a filter. It isn't a plug that has to be changed or removed. It essentially closes off the part of the heart that forms these clots. And so it's a lifetime decision. It's durable for the rest of the patient's life.
Wow. And what are the indications for its use? When do you know that you need one? Medication's not enough. Other options, cardioablation, not a fit for this patient.
That's right. So the biggest one is risk of bleeding. So in a patient that has a risk of stroke that's very high, but at the same time they have a risk of bleeding that's also very high, that is the ideal patient for a Watchman. A patient that's taking Eliquis or taking Xarelto and having no issues whatsoever, that's really not the right patient for a Watchman. That's a great way to protect them from having a stroke, just taking that medicine. But for that patient that can't tolerate it, either through an allergy or through bleeding complications or fall risk, those are the patients that are best served by a Watchman.
Joe,
Let's
that was going to be my
Nancy.
next. Real quick, if I could, sorry, I know we got to get to some of the guests, but follow-up question. Do you ever think, Joe, that in the future we may just be putting Watchman in everybody and avoiding
That's a good question.
anticoagulation?
It's very similar to TAVR or the
Yeah, that's what I was thinking.
transcutaneous valves. They initially were just put in the sickest of the sick. Watchman was the same. We put it in the sickest of the sick patients, and we see that kind of eroding back down into moderate risk patients. And I hope so one day. I think it's proving to be very effective, and a lot of patients are getting great benefit out of that. In the same way they got benefit out of just clipping the appendage or cutting it off at surgery. It's just a minimally invasive way to do what we've been doing for decades.
I know a lot of patients that would prefer just this one-off, procedure versus having to take their blood thinners every day and the bruising and the bleeding that happen just when you look at them. So that'll be interesting to see how that evolves. Nancy, go ahead and ask Joseph Bumgarner your question.
Okay. My heart stopped beating. Luckily, I had an EMT there who started giving me CPR. I was flatlined. The ambulance came. They got the paddles on me. They got my heart going, stabilized me in the hospital, put 2 stents in, and determined I needed a defibrillator. So they put a defibrillator in. It's been 9 years since that happened, and I have peripheral artery disease, and I do a lot of strenuous exercise. I'm back to it now. I line dance, and that's when my heart stopped. I was line dancing. My question is, should I watch my heart rate? How much exercise? Should I know when to stop? I didn't know when my heart was beating, felt like it was beating out of my chest. So I think that's when I had that arrhythmia before I had the heart attack, before all this happened. So my thing is, what should I do now? Should I be careful? Because I'm afraid at times that it's going to happen again.
That's a great question. Thanks so much for that question, and I'm so glad you're doing well. Can I ask you a question quickly? Has that defibrillator ever had to fire or shock you over these 9 years?
No, but my original defibrillator was a Medtronic, and it went bad. And it was the strangest thing in the world because there was these sounds coming out of my chest, and
That's
they
right.
replaced with a St. Jude medical device defibrillator. So since then I've been fine. It has never gone off.
That's great. And I think you made the right decision to have that put in. I have patients that play sports, play soccer, basketball. I have a professional skydiver that has a defibrillator. And so my advice to you is to go and live your life and do what you're passionate about and do your best not to worry about the defibrillator. I tell patients that defibrillator is like an airbag in your car. Hopefully you never need it, but you wouldn't drive a car without an airbag, right? But go on the trip. So do what you want to do. In terms of exercise, if your heart muscle has recovered and strong, and it's a good time to shout out to Cardiac Rehab, which is a great educational program after heart attacks for patients like you to go through, just to get kind of their sea legs again for exercise. But I think just regular aerobic exercise, 30 to 45 minutes a day, where you get your heart rate into that sweet spot of about 50 to 70% of your max heart rate. The easiest way to calculate your max heart rate is just take 220, subtract your age, and whatever number that is, just take 70% of that. That's kind of your peak heart rate that you want to sustain for that period of time. And do that 30 minutes a day, and you'll be in great shape.
Thank you, Nancy.
I line dance sometimes for 2 hours at a time. Perfect. And walk 10 to 20,000 steps a day. I swim, because I'm diabetic and I have peripheral artery disease. So the other question, is a Watchman one of the things for me? I don't know, because I do have peripheral artery disease and I take Plavix and Xarelto.
Only if you have AFib. I think if you developed atrial fibrillation, that's a good conversation to have with your cardiologist. But without AFib, no, you wouldn't need a Watchman.
Okay. I do see electrophysiologists at MUSC. So,
excellent.
Yeah.
Thank you so much, Nancy, for asking your great questions. Coming up right here on the Heart of Innovation, we have a couple more questions from our live studio audience. We'll get to those and more. So stay with us right here on the Heart of Innovation. Don't go away.
Everyone's clear on that side.
It always impresses me how much Nancy has been through and what she's doing. And it's so incredible. I love our network of patients and their courage and their perseverance. It's just amazing. I want to get to, we only have, Dr. Bumgarner, we have 4 minutes in the last segment here. We're going to come back pretty quickly. I want to get to Marcia and Douglas, but if Marcia and Douglas, can you keep your questions quick and on topic, and then Dr. Bumgarner will have you give us 30 seconds of last final thoughts on it.
And then, Joe, could you just for maybe 15 seconds touch on that whole?
Sorry to interrupt everyone. We're going to be live in 3, 2, 1, 0.
20 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Time flies when you're having fun. We only have a few minutes left, so let's get back to our audience. We've got a couple of folks who have questions. Marcia, do you have a question for Dr. Bumgarner?
Marcia, go ahead and unmute. Okay, we're going to go to Douglas. Douglas, go ahead and unmute and ask your question.
Thank you for joining us. I'm 63. I have PAD. I've been diagnosed with atypical hydrotropic cardiomyopathy. I had a myectomy a year and a half ago, and my defibrillator went off 3 times in 10 minutes, like 3 days after my surgery. Now, I experienced points in life today where it feels like there's a vibrator in my heart that comes and goes. Does that sound anything like the doctor had mentioned one time I need to see electro, but I haven't seen one yet?
Yeah, it can be really difficult to tell the sensation that you have in your heart if it's an electrical problem. But if you have a defibrillator, as you say, in your heart, the great news about that is that you have the best way of reading the electricity from within your heart. That device, if it's in the heart muscle, and there are some different variations on that, but if there are wires actually inside your heart, those wires can tell an electrophysiologist or a cardiologist exactly what those heart rhythms are doing at the precise moment that you're having those symptoms. If it is an electrical issue, it's pretty easy to see that. So I would encourage you to see an EP to look into that.
And Marcia has sent her question in. How reliable do you think Apple Watches are for AFib?
So that's a great question. And I would put Apple Watches and the KardioMobile on equal footing. We did some of the sort of initial comparison research for this at Cleveland Clinic, where we compared reading 12 lead EKGs to an Apple Watch, reading in 12 lead EKG to a KardioMobile. And essentially, those devices are about as good as the generated computer reading that you get from an automatic 12 lead EKG. When you have a cardiologist look at it, the sensitivity and specificity go up to almost 98, 99%. So what that really says is it creates a really clear tracing. The algorithms are really good. But to nail it down, having your cardiologist look at it too and confirm it really seals the diagnosis. But they
Joe,
are.
should I?
Go ahead.
Sorry, real quick. Should I be worried when my Apple Watch tells me my heart rate's less than 40?
I used to tell patients that God didn't give us a heart rate monitor, and we probably should take it off when we sleep.
But that dovetails into the thought with the athletes.
That's right.
At what we alluded to at the beginning of the show, right?
Yeah, so we were talking earlier, why do athletes go into atrial fibrillation? And I think it's kind of 2 sides of a coin. They exercise really hard, and they're putting their hearts under a lot of stress for a long period of time. That might be part of it. But then the other side, most athletes have a really low resting heart rate in the 30s and the 40s. And so there's just a lot of time between each heartbeat that comes along where another pacemaker in the heart can wake up and start to fire electricity. And that's where those pulmonary veins, which are these bad pacemakers, these bad spark plugs, I think start to fill in some of those gaps on these athletes and fire inappropriately and trip them into AFib.
Now, when it comes to AFib, though, this is something that shouldn't be missed. This is something that if you go to your annual exam every year and the primary care physician puts their stethoscope to your heart, this is something that should not be overlooked. Am I correct? Or is this something that they can't detect?
So listening alone or feeling a pulse that primary care doctor would pick up on an irregular pulse, and then they would need to confirm that with a full 12-lead EKG.
Okay.
But that is often the thing that tips the primary care doctor's ear to the possibility of an arrhythmia. And I agree with you. An annual exam for that reason is very important.
We
What do you
have.
think of those
Go ahead, Kym.
new echo stethoscopes? Have you heard the EKO stethoscopes, the world's smartest stethoscope? They're trying to get those into the hands of the primary care so they can be a little bit more in tune to these earlier signs of heart issues such as AFib.
It sounds like a good idea. It sounds expensive.
Yeah, 30 seconds left. I'll just say that a lot of us, because we have access to so much technology, the stethoscope may have gone the way of the dodo. But thanks for joining us. Have a fantastic weekend, everybody. Dr. Bumgarner, appreciate your time.
Awesome. Dr. Bumgarner, do you
Hey.
have just a few more minutes? We have some patients that want to just get in a few more questions.
Sure.
Do you mind? Okay, great. If you wanted to start to ask a few more questions of Dr. Bumgarner, Marcia, do you want to go ahead and unmute?
Yes. Thank you, Dr. Bumgarner. When I was diagnosed with PAD, I went and got an Apple Watch so I could monitor my walking and some of my health issues. And when I did, I started like 4 or 5 times a week in the morning. I would wake up and it would say I had AFib while I was sleeping. And so, long story short, I went and got eventually an ILR inserted. And it's really calmed down, but I quit wearing my watch at night, and it's not picking up. The ILR is not picking up nearly, hardly any AFibs. What do you make of that?
Yeah, I think at the end of the day, the watch is doing the best it can to get a EKG signal from your wrist. But the loop recorder that you have inside, it's just it's a more sensitive detector. And I think I would take a little bit more peace of mind if that loop recorder is telling you that you don't have AFib. That's a pretty good. Those are really good algorithms in those devices, and so I think that.
I mean, it has detected them, just not nearly as many anymore.
Not as much, and that AFib starts as a small thing. It sort of comes and goes, and for a lot of people, it doesn't grow, it doesn't become a big problem. But for a lot of patients, it sort of hits this growth curve. After having it for 3, 4, 5 years, and it really starts to take off. So, certainly keep an eye on it. In case if it starts to increase, I think that's when you'd want to have it treated either with medicines or an ablation.
Thank you.
You're welcome.
Douglas, did you have another question for Dr. Bumgarner?
Yeah, the correlation between PAD and the heart and the symptoms, is there? And AFib, the more we exercise, the better off that gets.
I think the right exercise, this idea of lifting as much weight as you possibly can and doing bench presses, and deadlifts up to 500 pounds. If you measure someone's aortic pressure when they're doing that, it's insanely high. That's not the kind of exercise. The kind of exercise that's really good for your heart is good aerobic daily exercise that doesn't overstress your heart, but just the usual goal that I'll tell patients is if you can exercise for 45 minutes and you hit a point where you can carry on a conversation, but you have to every once in a while take a deep breath, you're at a good spot.
We talk a lot about walking 30 minutes. 30 minutes. We got to walk 30 minutes to build those collaterals. Now, does the pace of our walking make that big a difference between the collaterals that we need to build in our heart and building our heart?
I'd probably defer to John on the collateral question.
Yeah, so I've got to run, but I will answer that. And I want to thank Thank you, Joe, for being on the show. I would say that when I tell people that what pace they need to walk for PAD, it's such that they get claudication or they get the discomfort, walk a little bit further and then rest. You need to walk to get the pain, I think, to develop the healthy collaterals. And then I also tell folks the same thing that Joe said, walk at a clip such that you can potentially talk to the person next to you, but it's a little uncomfortable. The whole like kind of holding hands and, you know, having a conversation, that doesn't do it, in my opinion. But anyway, thanks for joining. I got to run. See you guys. Cheers.
Thanks, John. Yeah, that's a good question. We always get asked that because we have some patients that will say, I'm in cardiac rehab and I can't even literally make it 10 minutes where I have to stop. Am I getting the same cardiac benefits as a cardiac patient who doesn't have PAD and can make it and sustain those 30 minutes of a higher heart rate? And we have some doctors that will say, I will treat a patient with PAD so that they can sustain a certain pace and a certain heart rate for 30 minutes in order to maximize the benefits of cardiac rehab. And then I have other doctors who treat PAD that say, absolutely not going to treat them. They're just an intermittent claudicant. Their heart's fine. They'll still get the same benefits. And here are the patients caught right in between. And their life and limbs are in jeopardy. And there's no definitive agreement as to what to do. So what is your suggestion? What's your experience?
Anything's better than nothing. And and I'd push John a little bit on walking is not good. Walking's great. And there's data that there's some great studies out of England that show that you don't have to jog or run. You can walk. You just have to do it at sort of twice as long. You get the benefit a little faster when you're jogging and running. But if you walk, you cover the same distance. It's going to take longer. There have been comparison studies that show that the benefit is still there. I think that listening to your body is really important. It's the kind of thing that we don't have to train to become Olympic athletes to have a healthy heart and to have aerobic health. And I think just getting out there, making it a habit, each day, spending 30 minutes, just, for yourself, it's good for your mind. It's good for your soul. It's good for your heart and your muscles. And, we're meant to move. And I think just anything is better than nothing.
You were mentioning in one of the commercial breaks about the NBA, the athletes having, hearts that looked like they had some enlarged hearts. Is that something that is a concern for you when you see that? Is that healthy for them, or is that's something that is a concern for later on in life? So they get past their prime and then suddenly they dropped out of a heart attack in 10 years.
Yes.
After they retire.
Those risks are there. There is some degree of normalization when they stop the intense exercise. But, everything in their world is geared to get them bigger, stronger, faster. And there's no amount of advice you can give to a professional athlete at that level when it comes to that. It is a risk. But, for me, that would be like someone coming in and saying, that x-ray machine that you're standing right next to is really dangerous. You probably shouldn't stand quite as close, but at the end of the day, it's our livelihood. So it's a huge issue. It really is. And this is why NFL players and NBA players, their life expectancies are shorter, and it's a big problem. And the system around them, what's so fascinating, when they would come in, they would get stress tests. And you think about doing a stress test and you want to do it to your maximal fatigue. They would absolutely not do that. As soon as they hit their peak heart rate, their agent or their coach would take them off the treadmill. They don't want to know. They don't want to know what happens. They don't want to see it. They're not there for the health. They're not there to see how healthy they are. They're just there to see that they're healthy enough to exercise, to do their job.
And I can tell just by your tone that that's concerning to you, being a doctor and knowing what you know.
It's It's the way of the world, isn't it? I mean, they're motivated by so many other things, but
But do you think you could make a difference somehow in these athletes and their longevity if
we
they would
are.
only max out right then and there so that they would know? And then that's where you can come in. The more you know, the more you as a doctor can come in and help them to not only prolong their career, but also prolong their life.
That's right. That's right. I think it's a great opportunity to build a relationship, to let them know that these are things they're going to need to follow through their life, that these are conversations they're going to need to continue to have. Um, and I think just their awareness that they're not immortal and that their hearts will need to be cared for and monitored. There's been a lot of good work, a lot of initiatives that those professional organizations have done to get physicians at many different levels, mental health, cardiovascular health, um, all of these things. And so we go to the combines, we go to the drafts. There are physicians at all of those checkpoints now, and there didn't used to be.
Is there some advice that you can give, let's say, to parents and young athletes as they're just starting out in this journey? They realize that, you know what, I have a certain talent and I think I'm going to go all the way. What are some of the tests that, one, they should get ahead of time to make sure that their heart can withstand the endurance training that they're going to endure, and how much of it they can endure with their particular God-given bodies?
Yeah, I think that um, others may disagree with me, but I do think that teenagers that are in sports, they really do need an electrocardiogram at a bare minimum, a 12 lead EKG, and many of them also need an ultrasound of their heart, because there are patients out there that have cardiomyopathies and they don't know it. And one of the risks of having sudden cardiac arrest is strenuous exercise. And so doing that enough in athletes, you are going to pick up kids that could potentially die, on a basketball court while they're exercising. And the other side of that is we want to be a society that helps schools get defibrillators and put them in gyms and put them on football fields and have these defibrillators ready to go, because these kids, it's going to happen, and having trained personnel there ready to react is really, really important.
And it is so important, especially to be prepared to know your body and to do whatever you can and whatever insurance will potentially cover, right? To prepare for this endurance training. Because my younger brother is a really good example that he ended up with the Arnold Schwarzenegger syndrome, is what I call it, the bicuspid valve defect.
Yeah.
And he didn't know that until he literally the doctor said he was just months away from a heart attack,
Wow.
because he was doing massive weight training and he was entering into what do you call those, bodybuilding competitions, and just going the extra mile, and it wasn't right for his body. And so he had to literally completely do 180 there. And now he can no longer do that because his body's just not designed for it.
Mm-hmm. Mm-hmm.
But he should have known that before, and that's frustrating that he didn't know until it was almost too late. But at least it wasn't too late.
That's right. And not a completely painless, non-invasive test can pick that up. I'm glad they found that for him.
Yeah. I want to just turn to the audience. I don't want to keep you all day. It's a beautiful Saturday afternoon. Any other questions? I think
I
Douglas
got a
wants to jump in.
question.
Go
Yeah,
ahead.
and you were talking about the treadmill thing. That reminds me of that football player that almost died on the field. I wonder if he got to that point and they said, no, we don't want to. If y'all had known that, could that have been prevented? You know what I'm saying?
I do, and I often, I use that example, that player from the Buffalo Bills, a lot of times when patients are deciding about, nobody wants a defibrillator, nobody. And so as they're thinking about it, often we'll talk about that event and how really what saved his life was the defibrillator. It wasn't, CPR helps and medicines help, but the thing that saved his life was the defibrillator. And you're right. Could he have gone just too far and too hard? And I think that what's been interesting about that, they never really released a lot of information about what caused that for him, and it brings a lot of questions to my mind about maybe what is going on there. But that just underscores again the importance of having a defibrillator ready or in a sports setting in case something like that happens, because it's so treatable, it's so reversible.
One more quick one. Atypical. Is there a way to describe what that would feel like in somebody, or is it different for everybody?
What would feel like?
The apical
Having
hypertrophic
no
cardiomyopathy.
having that rhythm, that different rhythm.
Yeah. So
You said earlier, some
Mhm.
people know it and some people don't. My first thought was, how would you actually know if you were?
Yeah. So for AFib, the most common symptom is fatigue, is feeling tired. And that is a hard symptom because there are so many things in our life that make us feel tired, and you can kind of brush off fatigue for weeks and months and maybe years and not react to it. A lot of people think it's going to be palpitations or chest pain or shortness of breath, but fatigue is by far the most common symptom and the most common reversible symptom when folks go back to normal rhythm. So I think just paying attention to your body, it's another reason to exercise. When you exercise, you're doing your own stress test every day. If something's changing, that's your way to pick up on it. Let your doctor know about it. So, if there's something going on, they can catch it and help you.
We always say to the patients, don't argue for your own limitations. Don't make excuses. If you're feeling fatigued, take note of it. Don't just blame it on, oh, well, last night I didn't have a good night's sleep. Okay, well, then last night I didn't have another good night. And then last night I didn't have another good night's sleep.
Yeah.
I'm just tired because of that. And that's what my dad did. And the doctor, cardiologist, told him he was literally just months away from a massive heart attack.
Yeah.
Because he kept saying, well, no, I just have an excuse for this or that. Really take note of what your body's telling you. And I think that's the most important advice that you've offered, through this, along with so much other great information. Thank you so much, Dr. Bumgarner. Any final thoughts before we let you go enjoy the rest of the Saturday afternoon?
You guys have a great Saturday. Thanks for the opportunity, Kym, and look forward to it again.
Yeah, we would love to have you back any Tuesday. I can send you a Calendly any Tuesday for the rest of your career. Happy to have you on. I put it way out there. We have our What's Up Doc Tuesdays, and every Tuesday we just allow people with PAD and CAD, to come on and just ask whatever questions are in their heart.
Right.
And so you can pick any time, any Saturday. I even had one doc, get me up at 5 o'clock in the morning one morning. So I'm out here on the West Coast, but it's on your schedule and whenever you're available. So happy to have you on
for the opportunity. I hope you all have a good Saturday.
Thank you so much, Doctor. Appreciate
bye
you.
now.
Bye. So thank you everyone for jumping in. I think that was a really great different session. I love talking about the heart. It's something that we deal with every single day. And especially I'm dealing with so many patients that end up with AFib and the doctors say, oh, I don't know why you're clotting. It's not possible for you to have bilateral clots below your knees. And then we come to find out that they have a serious case of AFib and they're just throwing clot after clot after clot after clot. And so I think that this is something that, especially for PAD warriors, it's something to take note of. Because it can develop over time and it can exacerbate the PAD and the symptoms. So
not only that, but think about, like you were talking, the Olympic people, the marathon runners that can do 3-minute sub-minute miles, and they may not know they have this. It's like that's kind of crazy thinking that they can do that, but yet at the same time may have these conditions they don't know about until something happens.
Yeah, exactly. I mean, you really don't know when, what is too much for your body, right? So we always say, don't compare yourself to anyone else because we all present differently. Our genetics are completely different. No two people are exactly alike. Even twins are not exactly alike. You present differently. You have different symptoms. You have different lifestyles, different thresholds for pain and tolerance. Different deficiencies in nutrients.
What about genetics?
And exactly, genetics are always different. And whether or not you've triggered some gene to go into effect. For example, for me, I ended up with the COVID vaccine and the rheumatologist says, for me, that triggered a gene in my body. Not to say that something else in the future would not have triggered it, to make me autoimmune. And I ended up ANA positive, which is a blood indicator for autoimmune disorders. And so you anything, everything, just like some people smoking, I have people that have lived into their 90s with smoking and then suddenly ends up on an oxygen tank, but nothing else up until into their 90s. But then we have others that are even in their 20s right now that are ending up with critical limb ischemia because they started smoking when they were 13. And it just depends. No two people are ever alike. And the key for each person is do the best you can to live a healthier lifestyle, what that means for you. But we were just having this debate in one of the heart disease groups on Facebook where people were telling a certain patient that you need to be on the Dean Ornish diet, or you need to be on the paleo diet, or the carnivore diet's going to kill you, or the keto diet's going to kill you, whatever it might be. You can't tell other patients that this is the right XYZ for you because you don't have all of the information to make that decision for that patient. It has to be something that is personalized to each and every patient, because for me, for example, I can't have zucchini. Zucchini is one of my favorite foods in the entire world. I do everything with it, and being gluten-free, that was my staple, to make zucchini noodles almost every day. And maybe that for me ended up being too much of a good thing. But for me, it turns out I'm allergic to zucchini and had no idea that that was having any impact on my body.
Is that like what I told you about the blueberry? I heard about the blueberry story.
Correct.
And how
Correct.
blueberries are the worst fruit you can eat.
And that was, I know. I just don't like those blanket statements because blueberries have so many amazing antioxidants. They're clinically proven to have an impact on the blood. But if you're allergic to them, they're not going to be good for your body. So they can have all the antioxidants in the world, but if they're having a negative impact on your body, they're not a good thing. So pay attention to your body. Just like for my brother, while let's say one of these Olympic athletes are out there and they're, bodybuilding, they're doing great things and winning gold medals and not having a problem. For my younger brother with a bicuspid valve defect that was discovered by accident, by the way, bodybuilding would kill him. And he comes across, he's a fit, young man that does everything in the world to try and stay healthy, but doing the same thing that this other man with a different set of genetics would do. It would kill my brother, but yet this guy is going to be successful and live, right?
Were you a reporter when that y'all remember Lynn? His name was Lynn. He was a college basketball player. He died on the court.
I remember the story. I wasn't.
Come to find out later, it was heart valves, and he ate properly. He didn't smoke. He ran. He was in perfect health. But look what happened.
Exactly. So you really got to figure out what is right for your situation. By the same token, I think that Dr. Bumgarner made a really good point that sometimes you just got to live. Sometimes you got to live within reason and live life to the fullest and do things you love. And I know, for example, with my younger brother, there is still a certain amount of activity that he does, which he knows are going to put him at greater risk of a heart attack with his situation. But he needs it. He loves it. He thrives on it. It makes him so happy. And so sometimes you have to take that into consideration and live the best life for you. You can't live in fear all of the time. You have to maximize your life and live each and every day to the.
So I had my last cup of blueberries this morning. So if I go home today, at least I'm going to be happy.
I'm going to keep him. I'm just going to watch better,
I have mine. I have my cup every single day. And a big dose of ground chia seeds too, which you have to make sure to watch out for, we discovered, if you're on high blood pressure medication and insulin. You got to watch that. I guess chia seeds work too well to lower the blood pressure and to
Do they
lower your
counteract?
A1C.
Do they counteract each other, or what do they do?
The chia seeds, supposedly, according to the study I read last week, it can actually lower in large amounts, can lower your A1C and blood pressure to the point where it would affect the dosage of your medications. So you would have to adjust your medications accordingly. And so you always have to talk to your doctor if you're on, and we always say, when you're on these medications, make sure to do your research, because supplementation is not something that doctors are very familiar with. Most of them don't have the experience. A good person to ask about those things is actually a pharmacist. I think pharmacists are underutilized. We have a pharmacist that works with us, and I probably should get her back on and do a regular Q&A with you guys, because she does a great job in doing her research and understanding the interactions between foods and medicines and supplements. So she
How
would be a
often
good
do
one
we
to have
ask
on.
that? That's a great question, because how often as patients do we ask that of our doctors? What can I eat with this medication? We
But is that
really
something?
we don't
Can they
really
cover
talk
it all?
about that, do we?
But can they really? No, we don't. And I think that we should. And I think we should come in with a list of things that, for example, if I was you and I was on high blood pressure medication, or I was on insulin, I would be listening to this going, I am going to go talk to my pharmacist. I'm going to talk to my endocrinologist, and I'm going to say to them, hey, I eat, this amount of chia seeds. Is this going to be okay? Or will this affect my insulin dosage? Is this something that I need to cut down on? And guaranteed, what they'll likely say, everything in moderation. Don't overdo anything. So that's really the catch-all line that most of the doctors use, because they really don't know. So that's where Dr. Google does come in handy, and making sure to take those Dr. Google assets that those gems that you uncover, and coming up with those critical questions, those poignant questions that you can go to your doctor.
What about our nutritionist that we have? Is that something that she could probably help us with too, couldn't she?
It is, but as you know, we always make sure that people understand that it's not a replacement for the advice from your own medical practitioner, who knows your situation best, knows your entire medical history. But what our nurse practitioner, what our pharmacist, what our doctors that we have on, during our shows, during our live broadcasts, that you can research our library of videos, that you can end up in our groups at padsupportgroup.org.
YouTube.
All of the physicians, YouTube, all of the above, like, subscribe. Just kidding. I'm not, though. But, all of those folks, the best thing they can do for you is empower you with the right information to have a more productive and conversation with your doctors, so that your doctors can help to customize a regimen for you. And unless you bring some doctors the questions, they won't even think of, for example, something off the beaten path like beetroot powder or chia seeds, or they may not even talk about, although they are talking more and more about turmeric and omega-3s, especially before going in for a procedure. They tell you to get off your blood thinners, and then don't take those supplements either, because they've become so mainstream these days.
And the only thing about the Google, though, for me, I have to be careful, because I'm going to usually end up on the Google site that's going to have me dead in the next week.
Because, if you have PAD and you Dr. Google,
I'm going to be all over the place, and I'm not going to end up at the right place. I'm going to end up somewhere where I'm going to sneeze tomorrow and I'm going to die, or.
It did for me. It was interesting, because I ended up where I mean, sometimes when you look at what your medical practitioner may tell you, you have to realize sometimes that, the blood work, and when you get those results, it's within a range that's determined for your demographic in your area. So sometimes I like a practitioner that can go beyond what's the range for that area, and think outside the box and say, hey, you are on the low end of vitamin D. And while you're in the normal range, we still think that you need to up your vitamin D supplementation in order to get you to a higher end of vitamin D, especially for your age. So even though I'm in the normal range and my primary care physician would say, oh, there's no red flags, a functional medicine practitioner or the nurse practitioner that is focusing a lot more on women's health, and she likes to customize medicine, our doctor, our nurse practitioner Deidre Arms will tell patients, if you're on that lower end of normal, you might want to just bump your supplementation of vitamin D up a little bit more. So you do have to take some things with a grain of salt and be able to ask more questions. I mean, that's the same thing when it comes to B vitamins. I was at the lower end. My primary care said, you're fine. I have the MTHFR mutation. So if I remain on the lower end of what would be normal, maybe for my demographic in this area, maybe they don't have the MTHFR mutation. And because I have it, I need to up my B vitamins so that my body has a better opportunity to turn food into fuel and make sure that my homocysteine levels, which are like nails on your artery walls, make sure that that enzyme is being able to broken down so that I have enough in my body. So you really do need to, sit down and scrutinize your blood work and get multiple opinions, not just from your primary care, but making sure to find that nutritionist, that dietitian that can, really analyze that data, analyze all of your comorbidities, your other mineral deficiencies, and customize a plan that's right for you.
Should they have some experience with PAD? Because I understand if you have another condition, it's one way, but if you have PAD, it's different for each condition that we have, isn't it? For how you scrutinize each thing, right?
Of course.
Should that dietitian understand, like if you go to hire a workout partner, somebody to train you, they need to understand some of this a little bit, because they might end up have you do things that are not good for you.
Right. You might end up having someone that is just a standard. They got their 6-week certificate in athletic training and they're going by the book. They just got out of their training. They just got their certificate and they're just going by the textbook as to what to do, versus someone that maybe has been involved in it for a while, someone who maybe has back injuries or some sort of comorbidity that led them to improving their own well-being, and then in turn wanting to help others with that same situation, that same ailment, to maximize their workout routines. You got to find someone that can customize for you. And with PAD, you might have certain endocrinologists that are, fantastic in general, and they want to get you to an A1C of 6.0. And for that, it's really good. But they don't understand that even with, a 6 in A1C, that you are at risk of having your arteries scratched by those, even that one extra sugar molecule. And that is causing damage to the arteries, especially below your knees. So you need to have an endocrinologist that understands, hey, you know what? I have PAD, and I might need to take a more extreme approach to lowering my A1C than a general individual that doesn't seem to have all of the damage happening to their arteries right now. And so that's really important, that you don't rest upon your laurels, that you really push your doctors to customize the care that you are receiving. And that's why we always suggest getting a second, getting a third opinion, and making sure that you get a variety of opinions, people from different backgrounds, different experiences, different practices. So your endocrinologist may tell you one thing, but then you go to a functional medicine practitioner, they'll tell you another. You might go to a nutritionist or a dietitian, they'll tell you another. And you might have a complete differing opinion between a nutritionist and a dietitian, because maybe the dietitian has a lot more education and experience. And you might get a different opinion from a general dietitian versus someone that specializes in diabetes, if that makes sense. So the one thing, because Douglas, you bring up a really good point and leading me to this soapbox, is you got to be careful of literally only going to those people that are telling you what you want to hear, that make you feel good about what you're hearing, because they affirm what you want to be doing, right? So, for example, with my dad, he only wanted to go to the dietitian that told him and made a deal with him that his one non-negotiable was to have his one cocktail every single night. That was his one non-negotiable. He told the dietitian, I will change everything on the planet, but I want my one cocktail every night. So how do we make that happen? And they made a deal. He has his, handful of nuts along with, his, 1.5 shots of his vodka, and that's what he has, right? But his other cardiologist was like, nope, no alcohol, absolutely nothing. He is not going to listen to that cardiologist or even actually consider what they're saying because the dietitian told him what he wants to hear. And I see this all the time. We just had a situation in our group just last week where someone said, don't tell me anything I don't want to hear. I'm in the hospital. I just had this procedure. So don't tell me anything that's going to make me have regrets. Well, we're not here to blow smoke up your skirt, and we're not here to make you feel bad. That's not what we're here to do. But if us telling you the facts and helping you to become a more empowered patient is something that makes you feel bad, we're definitely not the right group for you. We're not the right YouTube channel for you. We're here to empower you with the most information that we can and the critical questions that you can ask your doctor so that you can become a better informed patient and maximize the options that are out there in our healthcare system. It's just like with politics, you can go to one station and say that's the holy grail because they tell you everything you want to hear, versus literally making sure that you are going across channels, hearing a little bit of everything, even if there's something else that supports a different point of view that you don't necessarily agree with or want to agree with or want to even acknowledge. But it's so important that you literally just take a deep breath and take it all in and be flexible enough that you're willing to adapt based on what you're hearing so that you always have a contingency plan.
The hardest thing human beings need to learn, or the hardest thing we do learn, is learning to listen, because we listen generally for what we want to hear.
Yep.
So that we can respond.
Yep. So we say you just can't sit there and argue for your own limitations. Arguing for your own limitations is detrimental to your health and well-being. But arming yourself with the right information, let's say you do end up with a procedure that, and Douglas is the first, he ended up with a procedure that is supposed to be palliative care. And it was a last resort. He didn't have a choice. He didn't know any different. He wasn't empowered with this information. But now he is. And because he said, you know what, I acknowledge that it's not something that should be done every day or is being done every day. And it rarely should be done. But now that I'm acknowledging it, where can we go from here? Empower me with the critical questions that I need to ask my doctor, and empower me with multiple options out there, different doctors, different opinions, different tools, different techniques, different philosophies, so that I can move forward from here and I can thrive.
That's where we share our experiences, though. I shared my experience with this procedure that I had that she just did, and she didn't want to hear or didn't want to see pictures of what I look like now with that procedure, because she just did. It was like the doctor was saying with the athlete, they go so far and they don't want to know the rest because they only want to know this.
Yeah, such a good point.
So it's like, and I finally said, okay, because she said she didn't want to hear any more about what I live with this procedure.
Yeah.
So that is the point.
And it's not to, help. Knowledge is power. And if you have the knowledge, you can work with people to process that knowledge. Some people just don't want to hear it. There's some things sometimes that when I'm watching the news, sometimes I just don't want to watch the news because I just don't want to hear the negativity going on, because I know myself and I don't know how to process it. But I will say to my dad, for example, because he's just constantly in the know, I'll say, you know what? I know that I do need to know what's going on. I know that I need to put on my, big girl panties, and I need to learn how to deal with this information and process it. But I'm not ready for that right now. And when I'm ready, here's how I need to hear it. And here's
you
what
also
I'm going
need
to
both
need help with in
sides.
processing it. Yes. But it's being honest to say, you know what? Maybe I'm not ready to hear it right now, but I know that there's something that I do need to hear. And let me be honest with those who are around me, and let me surround myself with people that can help me in processing that information when I hear it. So that's why we're here, is we're here to help you process the information that maybe you even don't want to hear, right? There's a certain truth to Dr. Google saying that people are diagnosed with PAD ended up with 5-year lifespan. There is some truth to that, because there are so many people that are not being diagnosed at an early stage, and they're only being diagnosed when they're a toe step away from amputation. And it's not because of just their legs that they only have this 5-year mortality rate. It's because no one at that point has even checked their heart. So even when they do discover that their legs are at risk of an attack, no one bothers to check their heart, which is why working with us and saying, you know what, I hear this information, I'm scared, but I'm going to come to the Global PAD Association. I'm going to go to padsupportgroup.org, and I'm going to get the support I need to process this information and help extend my lifespan, because I'm going to become a more empowered patient. I'm going to know when I come to the Global PAD Association and go to their YouTube channel at youtube.com/the way to my heart, that I'm going to get the information I need to make sure that I am taking every step that I need to prevent having a leg attack and a heart attack and
You
a
can do the
stroke.
YouTube also and hit like on all our bit, because there's a lot of information on our YouTube channel also.
There is so much information there. And, I get questions every day from people asking, can I donate? How do you support this 501c3? And the best way that you can support us is watch the videos, because right now we have our YouTube producer, Josh, who volunteers his time every single day to help us to produce this content, to educate all of you. And YouTube has acknowledged the work that we've been putting in, and all of you coming and watching these videos. And so now they've said, hey, we're going to help pay you for people who are watching your videos. So if you can take a moment and just watch a video and watch a commercial that's on these videos, they pay us in pennies for every one of those clicks, every one of those views. They're actually helping to save life and limb, because every penny that comes into our 501c3 literally goes to helping to save life and limb. And that's not just in general. We're not talking overhead. We're talking directly to cover copays, deductibles, transportation, much needed medicines, healthy food, exercise equipment, to make sure that patients with PAD are getting the life and limb saving care they need.
Yep.
So thank you everyone for joining us.
Well,
Next
I have
week,
one more though. One more.
Yes.
So the rainbow, the Skittles then don't fit under the rainbow in that sense, then, do they?
Are you going to end on that? Are you going to argue for your own limitations, right, Nancy? Are you seriously? So when we say taste the rainbow,
That doesn't mean Skittles.
that doesn't mean Skittles, although we're okay with having a treat every once in a while. We had this debate in the group that, you have to joke, you have to have humor in these things. And I think that we're all logical enough that I could easily say, oh, Douglas, oh my God, that's bad. Don't even talk about it. That sends the wrong message. You need to lead by example. we had that happen in our group this week, where someone was making a joke about hibiscus tea, that she found out that hibiscus tea was very healthy. And so she actually has hibiscus tea in this concoction she makes with turmeric, etc., every morning, and she downs it so that she can end up trying to do what she thinks is making her healthier every day, which is great. But she found this meme for this hibiscus infused vodka, and she posted it in our network, which caused a stir from people that suddenly came out of the woodworks. It's, alcohol is poison, don't do this, but they don't know her heart. And that having a sense of humor is really something that helps people heal. And not everyone's sense of humor is the same. Everyone has their own place that they're coming from with their humor, and you may not align with it. It might hit a sore point for you because you might be insecure about a certain topic. You might live in resentment that you have had to give up something in your life to live healthier. It might not be your non-negotiable. For example, with my dad, his one non-negotiable, he'll change everything in his whole life. He eats blueberries all day long. He eats nuts. He doesn't have all the sauces he likes. He, doesn't have all the, the multiple drinks in the evening. He has his one cocktail and he has his bag of nuts with it, and that is fine for him. He doesn't have to have his big bowls of ice cream and all the sweets he likes either. But maybe your non-negotiable is, I'm going to have my chocolate. But for him, that would be poison. And maybe for you, because you've chosen that chocolate's your non-negotiable and you're giving up alcohol, well, you know what? That's your choice. We have to let people be where they are and be positive and supportive and educate, right? Because we have some patients that have actually been told by their cardiologist, I want you to be having one glass of wine every single night, not, some $3 wine, but something with fewer tannins and a little bit more nice, wonderful grape seed in it. But they
You mean
need
no
it
Boone's
because
Farm?
oh, smarty. But for that patient, they would be on other medications for PTSD, like my dad, or anxiety, or other things, and end up with greater digestive issues because, they have this horrible anxiety. And one glass of wine calms them down. The resveratrol might provide some cardiovascular benefits for them. And maybe those benefits outweigh their risks. With every food, with every person, with every drink, there are risks, some more than others. But we really promote not, saying what is healthy for you, define what's healthy for you, work with your team to find what is healthy for you and get that customized regimen. And we're here to support you. Not everything we say, not everything we do is going to fit you. So take the information we give and work with your physicians, your care team, to create that customized plan that is right for you.
And
And
everyone in
that's our
here generally
philosophy.
has one of these, don't we? We use this to get to this group. See my finger? We use that to get to this group, didn't we? We had to scroll. No, if you're on the computer, if you're on your phone, you still had to scroll to get here. So if you see something that doesn't fit you, just pull that finger out again and keep on scrolling.
Keep on scrolling. Scroll on.
Or get out and go walk. Turn it off for a moment, get out and go walk. If you see something you don't like, doesn't fit you. What's Nancy?
Walk.
Walk, walk, walk.
And on that note, I think that is a perfect way to end the show and to carry on our Saturday, getting out and enjoying the weather and walking.
Thanks, Kym.